This is John Weigelt, your coordinating editor for CSAP 17 Audio Companion. I'm sitting here with Dr. James Tyburski, one of our CSAP 17 authors. James, can you share with our audience where you are located, your primary focus of your clinical practice, and maybe a little about how you spend your usual day, if you really have one of those?
Oh, thanks, John. Yeah, my name's James Tyburski, and I'm Chief of Surgery at Detroit Receiving Hospital in Detroit, Michigan. We're an inner-city Level 1 trauma center, and my practice is around acute care surgery and trauma, emergency general surgery and trauma with a small component of elective surgery. I'm not sure I can give you a typical day, but it involves either taking call for the emergency room, whatever comes in, or if the weeks I round in the ICUs, I round in the ICUs. And that's a mixture of, general surgery and trauma patients. So I make rounds with residents and occasionally fellows, and I help with the teaching service and, with the kind of the academic grand rounds. We still do that here, and I'm still an operative surgeon and, enjoy working with the clinical components and the teaching components that goes on associated with a major medical school.
We also share a common mentor, Dr. Robert Wilson, if I recall. What's Bob doing these days?
Well, Dr. Wilson finally retired.
Whoa, big move.
It was for him. He had, even after he retired from clinical work, he still was very active in the academic portions of the department and still came to the grand rounds every Wednesday. And until he recently relocated to Denver, you challenged him on literature reading even through 2018 at your peril. He was still very up to date on the scientific literature, particularly around surgical critical care and trauma.
I thank you for joining me today, and I have asked you to share some of your thoughts about various conditions a general surgeon faces related to topics from CSAP 17 that are located in the trauma category. Some of the topics actually come directly from CSAP 17 questions, and others will be taken from questions that were actually written but not finally selected for CSAP 17. Some of the discussions around some of those questions were pretty intense, and I don't want to miss the opportunity to pick your brain about many of these that a general surgeon may find himself or herself confronted with in their practice. So why don't we get started? And the first area I want to pick your brain a little bit about is resuscitation and fluid guidelines that seem to be changing all over the place. So how does your resuscitation protocols work for a patient who arrives with a normal blood pressure?
Well, in a trauma situation, a patient with a normal blood pressure obviously isn't as urgent to, resuscitate. You're looking for a patient, when you think of resuscitation, you're thinking about a patient who's hypovolemic when you're talking about fluid administration. So we usually establish IV access, and we do start some ballot salt solution at usually a low rate, but there's no specific with a normal blood pressure and let's say a normal heart rate. If they have normal vitals, obviously we are not too aggressive with fluid at that point. We do want to establish the IVs, but you don't do much as far as a protocolization for somebody with a normal blood pressure without any indications that they've lost volume.
Obviously, then, what about that hypotensive patient?
So, as you pointed out, this protocol has changed. So I think everybody's familiar with the 2 liters of balanced salt solution that went in first, and then we put people into the responding, partial responding, or non-responding categories, and then a non-responder we would start blood. That was a prototypical ATLS algorithm. I think we've switched more now to giving blood earlier. If somebody is hypotensive with an obvious blood loss, then we will start blood well before 2 liters of crystalloid being administered. It will go in right after we start establishing IVs. Again, when you use the word hypotensive, but if it's hypotensive and clearly, a substantial blood loss, we're much quicker to start blood than we were in the past, where if you waited for the 2 liters to go in, and sometimes 3 and 4 liters of crystalloid solution was going in, decades ago, and even more than that, they would get much more balanced salt solution than it was probably appropriate before blood was started. So we'll start it much more sooner now, almost from the get-go in a patient whose clinical scenario, deems it indicated, i.e. hypotension with substantial blood loss.
Now, does this always get you right to a massive transfusion protocol?
No, for the reasons that we're talking about how they respond. Some people respond very well to the unit of 2 or blood, and then we don't initiate the massive transfusion protocol. The ability to have blood available in the emergency room in a cooler does help, and that's a start. And there's, but we don't formally usually start the massive transfusion protocol unless the patient A didn't respond, or B, we're very suspicious or are aware of ongoing blood loss, non-compressible blood loss that we need to get to the operating room to control.
Well, let me ask you, because we don't really have a specific question about scoring systems for the MTP use, or massive transfusion protocol. Do you use anything, the ABC score or anything like that?
Well, we're aware of them. I don't think we routinely use any of them, like to decide to start the massive transfusion protocol. We certainly don't hesitate to use it, in the fact that it does allow, it's been thought out ahead of time, and it does allow us to maintain, blood component ratios that we would find more favorable than if we're doing it in a more, haphazard, if I want to use that word, fashion. So we're happy to start it rather quickly, but we don't initiate an MTP every time we give blood. Back to your previous question.
You mentioned blood component ratios. When you are using an MTP, are you always using a 1-to-1-to-1 ratio?
Here, we've been more inclined to use a 1-to-1-to-2 ratio. The literature doesn't seem to make much difference in 1-to-1-to-1 or 1-to-1-to-2. I think the 1-to-1-to-1 is certainly viable, and it's certainly a way to go. We've found it, and in my travels around the country, I've noticed it. Sometimes it's very hard to get a 1-to-1-to-1. If you strive for that, you end up with something more like a 1-to-1-to-2, where you're giving 2 units of packed cells to either the FFP or the platelet components. I think anything higher than a 1-to-1-to-2 ratio probably is suboptimal if in a massive transfusion setting. Obviously, if there's only a little bit of blood given, 2 units of blood, we've all given that, 2 units of packed red blood cells, without administering FFP and or platelets.
So the 1-to-1-to-1 is red cells, plasma, and platelets. And when you use 1-to-1-to-2, that's the 2 becomes platelets? Is that?
No. If I misspoke, so I'll go the other way. It depends on it. I'll do it 2 units of blood to 1 unit of platelets and 1 unit of FFP, fresh flow plasma. So it would be we would be using more blood than the other 2. So and I think it's that acronym of 1-to-1-to-1 and 1-to-1-to-2, I've actually seen it reversed a couple different ways. Either the red blood cells end up in the first or the last part of it. But I think you're like me. I like to put the red blood cells first usually, and so it'd be a 2-to-1-to-1 ratio is what we end up using here in the massive transfusion protocol.
Good point, Jim, because people get confused about what we're talking about when we just throw that ratio out, especially if they don't use it on a routine basis. I want to clarify something else you said. So you use that 1-to-1-to-2 or 2-to-1-to-1 for a massively transfused patient, but when you're giving blood and they respond quickly, you don't normally spend too much time worrying about the ratio of blood components. Is that fair?
That's fair, and I don't know where the trigger point is, but somewhere around 4 units for sure I will start to give FFP. So I may be starting that resuscitation if it wasn't a massive transfusion protocol at, if you will, 4-to-1-to-1, but then I would strive for the ratio from there, and obviously that could evolve into a massive transfusion protocol situation. I do think the other caveat here is that as blood banking evolves and we look at the future of how we're going to transfuse patients, I think whole blood has gained a lot of popularity, or certainly a lot of buzz, to use your word, about it. And I think there'll be many centers that will be using whole blood for trauma resuscitation. That eliminates the component argument there that whole blood goes back with the correct ratios. And if it's available, it's shown to be effective. And the military has quite a bit of data, recently on that. So I think that for the future, we may be looking back to whole blood, which we wouldn't have thought much about 15 years ago.
So does your blood bank ever provide you with whole blood for resuscitation in a penetrating trauma situation?
Not yet, but I hope soon. But the answer to your question is no, but I think we will head that way, and I think there'll be a lot of movement that way. Obviously, that's somewhat speculation, but it has all the, you're losing, the old argument was you're losing whole blood. Why not replace it with whole blood in those situations?
Yeah, the argument usually falls back on the blood banker's cost evaluation because they can make more, hate to say it, but they have more to sell if they separate the blood into its components rather than providing us with whole blood. So we'll have to fight that battle on a different playing field, I think. What about temperature? Do you always use a warmer when you resuscitate with either crystalloid or blood?
The short answer is almost and certainly for blood. We try to make sure we use warm IV fluids on the initial resuscitation, so we don't necessarily need a warmer. The fluids are hung warm. Obviously, you're not hanging blood warm unless it's a recent transfusion like the Army's done. But we do use, and we've had a couple different commercial warmers that seem to work pretty well in that situation. But we try to almost invariably warm the blood. The packed red blood cells are going in, even in a massive transfusion protocol or massive resuscitation protocol. We try to warm it in those situations. There's no great reason to give cold blood.
Okay, let's still stay in resuscitation as a topic, but let's talk about the alphabet, okay? ATLS, ACLS, classically has started with A and B and C, which happens to be our easy way to remember how you start looking at resuscitation. But the military has propagated this idea that maybe we should use CABC, with the first C standing for catastrophic hemorrhage. And they've even gone a step further, and some people have talked about MARCH, which is massive hemorrhage, airway, respiratory, circulation, and hypothermia or head injury. What are you teaching your residents these days? Are they getting confused about what the alphabet really starts with?
I hope not. However, I do think that, we were, certainly the mantra of ABCDE for the ATLS was used. I think in common sense, though, and in real life, we always simultaneously did things. In other words, if somebody came in to the resuscitation bay with a active hemorrhage, they would get direct pressure on that wound, first, even if there was an airway issue, it would be simultaneously done. So I'm not sure that the A of the airway is certainly important, but, direct pressure on bleeding was also something that was done pretty simultaneously. And even in the ATLS teachings and then certainly in the moulage, the initial resuscitation testing stations, that was also stressed. So I think, it's direct pressure on bleeding, the M of the MARCH, it was always important. The C before A, circulation before airway, is a slightly different concept, but it still applies, and that is that if a person is breathing on their own, even if they're hypotensive, and if they're somewhat obtunded, it may be better for the patient to try to hemodynamically at least temporize them before you go to intubate them, particularly if you're going to use drugs in the intubation part of it, etomidate or ensuccinylcholine and the such, because there are incidences both clinically and the literature starting to show up with these, is that the intubation itself can be quite hemodynamically compromising. And then if a marginal patient gets an airway when they were being ventilated with a good airway already and then getting intubated, that was probably premature to be done for somebody who needed to be, resuscitated. So it depends where the airway ended up. Obviously, an obstructed airway is something that requires attention basically immediately. You're not going to get anywhere with an obstructed airway. But to establish a definitive airway with intubation in a hemodynamically compromised patient sometimes should be delayed a little bit, and that concept is going to, in order to at least temporize in whatever way you can the hemodynamics of the patient.
Sounds like you're trying to make us think physiologically about our resuscitation and use some common sense and realize that ABC is just a mnemonic that we use to remind us of what we should be looking at. Is that fair?
I think that's fair. I don't want to downplay the fact we've all done it. We've all run into situations where the airway was a real problem, and you wouldn't, an airway that's penetrating or blunt neck injury, or foreign bodies, or there are times where the airway is the paramount issue, but many times you're confronted with a patient that is slightly obtunded, hypotensive, who's moving air, or at least has enough of an airway that with a little bit of supplemental oxygen or a little bit of, just a little bit of respiratory assist that will do fine in the short run from a respiratory standpoint. But if they're initiated to intubate them and use drugs that have hemodynamic consequences, you may have to find the patient to really decompensate and even arrest in the situation as they're being intubated. So if you can temporize those, control the external bleeding, maybe give them some resuscitation fluids in the form of balanced salt solution and or blood, you may find that they'll do better than having that acute decompensation. So, yeah, common sense is important. And, you wouldn't intubate somebody with a stable airway with some squirting femoral artery across the room. So I think both of those algorithms make some sense and in the real world are, just common sense applications in the clinical scenario.
Another issue that I see confused in the trauma bay at our institution is using a pelvic binder and how that relates to the ABC. So my question is, do you need an X-ray of the pelvis, or can you put a pelvic binder on based upon physical exam?
I think that the answer to that question is based a lot on the patient in front of you. There are times where it's pretty obvious a patient on clinical exam patient has a pelvic fracture. I don't know about how things are, where you are right now, but in Detroit, if everybody's BMI is 45, it makes that physical exam harder to decide. So I think it can be very difficult in a large individual to really get what you feel is a definitive physical exam. And you have a pretty unstable pelvis that is, cushioned by a lot of soft tissue that is pretty hard to, to diagnose that way. So I think it's always in your mind of, a place of possible blood loss when you're playing the game, sort of blood, where's the blood? Why is the patient hypotensive? The pelvis is certainly in that area. And I wouldn't wait to put a pelvic binder on if the patient had the physical exam. I just find it sometimes, hard to know by physical exam where that is. And a pelvic x-ray can be obtained pretty quickly. You're also in the scenario that you're looking for, deformities of long bone fractures. Hopefully by that time you've also, at least got an idea there's breath sounds on both sides of the chest, so you know that the chest isn't filled. The abdomen is a little bit more problematic when you're trying to decide where the blood is. You get the FAST exam out, but that comes a little bit later. But I think you can do it on a physical exam sometimes, but unfortunately, and I think as the national BMI rises, I think that physical exam's hard, frankly, in a true clinical scenario.
Now, you mentioned access when we started this discussion, so let's say that you can't get that IV in quickly in the upper extremities. Do you use IO ever or routinely?
I would say not routinely, but we do use it. I personally find an underused access point when you really need one in the resuscitation bay is the femoral vein. If there are things going on with the airway and around the head and neck and cervical collars and people listening, I find the groin a somewhat quiet spot. in the in the resuscitation that you can actually many times get access. It's not a preferred line for a long time, but it certainly can be a reliable way of delivering resuscitative fluid and drugs to a patient. And you can always remove it later when you get it. But I actually find, for me, especially with a palpable pulse, with or without the ultrasound, that is a viable option in a patient and somewhat underutilized, I think, in the community. And IL can be put in pretty quickly and stuff. However, it can be, it has, at least in our hands, variable, flow rates. They're supposed to be pretty good, and sometimes they work pretty well, but sometimes it requires some, pressure to get the fluids in. And I guess when I'm going to use this term, my generation, I don't know if it's your generation, John, is just didn't use that a lot, and those that don't do a lot of pediatrics didn't have a lot of experience with it. So I think it's a viable option. Certainly it is used here, and it is used in the field here even. In the ER, we do use it, I wouldn't say routinely, but my suggestion would be if you're comfortable with femoral access, that is a viable option with reliable IV, and you can also get your initial type and cross blood sample as you put the catheter in. So I find that, again, a quiet place in a busy resuscitation.
Do you use a long catheter or a relatively short catheter to improve your flow characteristics?
I use the shortest one I can get to use that way. It's not usually a 2-inch IV, so it ends up being a little bit longer catheter than I like. We certainly have used the standard just, triple lumen central line. However, that, again, you've eloquently stated, the flow rates aren't as good at that. But we certainly have used Cortises and things like, that, the old Cortis for the Swan-Ganz catheter. I find that to be an incredibly effective line in the groin for giving, volume.
Now, a final question related to our resuscitation protocols, and that is TXA, or tranexamic acid, was a favorite question in CSAP 17 committees. First, what is it, and what is it supposed to do?
TXA is a lysine analog, synthetic lysine analog, and it blocks the conversion of plasminogen to plasmin, so it blocks the fibrolytic pathway. ECAC, epsilon aminocaproic acid, was a precursor to that was much less potent. TXA replaced that, but these were substances, medications given to reduce the fibrolytic component. That was, the dissolving of clot in a trauma patient. So, and in massive transfusion protocols, it's been used in OB, also. So it is a plasmin inhibitor by not allowing plasminogen to be converted to plasmin.
Okay, and when you use it, do you make sure that the patient has a fibrinolytic state going on, or do you just give it?
Yeah, great question. That's a great question. So if it's given in the field, obviously you don't have any way of knowing that there's a fibrinolytic state. The most definitive way in my mind to know there's a fibrinolytic state is using thromboelastic, TEG technology. I think that's important because that you can get a reading from that. But obviously, when you're making these decisions early on, that's not always practical. But we do run TEGs on patients to guide a resuscitation therapy, and I think in that case it's used. But this thing is there are protocols where it's given in the field. It's given by either ground or air transport personnel. And just to dovetail into that, the administration of TXA, because of early trials, had an associated almost time pressure to it. And what I mean by that is that administered early, it seemed to have the best effects. As a matter of fact, in the original CRASH-2 study, it was a 3-hour or greater than 3 hours. There seemed to be an increase in mortality in patients that were given TXA. So we were kind of hit with the mantra, the earlier the better. I don't know if it makes much difference, 15 minutes versus an hour, or, in the first 15 minutes. But I think that was what pushed a lot of the protocols, and certainly the protocols that were placed in the pre-hospital personnel algorithms to give it in certain situations with ongoing hemorrhage.
Now, is it used in the field in Detroit?
It's used in the state of Michigan some. We haven't seen that much in a right local area where we're right now, but we've definitely seen transfers in by air or especially air, where TXA was administered in the field. by protocols by the air transport people. So it has been given in the field, and based on the data that was reviewed at the time, mostly from the two major studies. I think that probably everybody should have some working knowledge on are the CRASH-2, and then there's one called the MATTER, which is a military one. And I think there are reasonable studies regarding the use of TXA and its ability to, for sure, I think everybody would agree, reduce transfusion requirements. The use of it seems to make a difference early on, and those two studies also give slightly variable reports on the complications of it, with the military study showing some thrombotic events or an increase in thrombotic events versus controls, while the CRASH-2 study did not.
What do you think is going to happen? As I watch the literature, there's been a number of studies now where TAG, as you mentioned, has been used, and we find that the coagulation profile that shows fibrinolysis is not very common in the patient who receives massive transfusion or who has a massive blood loss. How do you think that's going to alter our use of TXA, or you just think we're going to carry on as we have been?
Well, I think it will alter it some if you use it. The problem is that the time frame. If the TEG becomes available earlier, that may influence it. And you're right. One would not have predicted that the minority of the TEGs would have shown a hyperfibrinolytic in trauma. In fact, some of them are hypofibrinolytic. And then there's the quote physiologic ones in the middle. I'm not sure what that means. I guess it's small, medium, and large, fibrinolytic activity. And the hyperfibrinolytic activity, if I remember the numbers right, were only 20%. So it is a curious find. So to again go back to your question, we will give the TXA early before we have any TEG data, and then we'll follow then some of the resuscitation later on, not using TXA, but if we're going to use something like cryoprecipitate or something like that, if we were trying to replace fibrin, we do direct our resuscitation somewhat by TEG, and so it's an interesting, and I found that as surprising and a bit disconcerting data point that's recently come up.
Well, let's leave resuscitation and let's move on to some specific injuries. And the first one I want to talk about is blunt chest trauma. There's been a whole lot of activity in the literature about chest tube size and placement for hemothorax. So I'd ask you, in Detroit, what size chest tube are you using when they come in and it's clearly a hemothorax?
Yeah, so I would say in the average adult, I use it 32 most of the time. Now that's, so you're asking me what I do. Do I have a lot of literature to support that? No. There's several studies that show 28s work as well as anything. I was taught by my mentor, Robert Wilson, you mentioned earlier, that you had to get a 40 in. And, to drain blood, and you would be squeezing this between, it would be a small person, and it seemed like we were doing a mini thoracotomy trying to get a 40 tube into them, when they were doing it, and it was the only reliable way to drain blood. I think that's been put to sleep, that you don't necessarily need a big catheter. I don't know where the bottom exists. I am uncomfortable using much less than a 28, a 24. I'm sure that would use for a hemothorax, that is. If you're asking me the tube I ask for in most adults is a 32.
How about in a woman?
Yeah, maybe a 28. I mean, you look at the patient, I would say in most adults, that's the one I have. It's a 28 or 32, and it's based on, again, what you're looking in front of you. I mean, I don't think it is one size fits all. And obviously the bigger the person, the bigger the rib interspace, the easier it is to get these things in. And also, I would say placing chest tubes, again, BMIs make a difference. In a hurry, you get people that have, large chests with a lot of adipose tissue, sort of floppy areas towards their axilla. There is a lot of subcu tissue versus the patient who's got from their skin to their pleura is 3 centimeters, is quite a difference. Anyhow, I 32, 28, in that range for a hemothorax. I will go smaller occasionally for a pure pneumothorax if I think it needs a tube.
Okay. Do you ever just use a small catheter for that hemothorax with rib fractures?
I have not. There's literature to support it. We have not. We've had people we've had some field placement of tubes or outside institutions transferring patients in that have had the small tubes in. They seem to work, and I'll use the phrase okay. You get some pretty good drainage out of them. Like any system, they can fail, but you can have retained hemothoraxes with 32 chest tubes, all 32 French chest tubes.
How about location? Do you change your location for a hemothorax versus a pneumothorax?
I do not. I think there's literature that shows it doesn't really matter too much where it's placed, at least initially, that if it's a clean pleural cavity, that is, there isn't previous inflammation and adhesions and all that, that if you place it, and at least they should all be directed posteriorly, hopefully away from the fissure, that they'll drain, particularly in a supine patient, pretty well. The only time that I really think I'm looking for, placement, if I'm actually in an open thoracotomy situation, you're placing one of those, L-shaped bent tubes, in the posterior diaphragmatic sulcus there, and, an apical tube, and you're putting two in. But I think about the fifth intercostal space is safe. Not too far off the mid-axillary line is good. You want to miss the breast and or the pec muscle, if you can, and I think the edge of the pec muscle sometimes is a kind of a reliable barrier to it, and I don't think you have to go down to the seventh intercostal space or something to try to lower the blood. So what I just said might be just a little controversial, but I think that it's a technique that I think most people, if you don't do that all the time, you want to know a technique for putting a chest tube that's safe and reliable, and it certainly gets rid of usually any hemodynamic consequences from a tension pneumothorax or something in that placement, and I think you'll get pretty reliable drainage for the hemothorax to assess how much blood's in the chest.
So do you try to put the tube posterior when you're placing it in the pleural cavity?
I do. I think that's something that does help because most of these patients obviously are supine, and I do think gravity does matter, but it is a pressure cavity when the lung, especially for patients under positive pressure ventilation, so it tends to move the lung up, and I think the fluid kind of flows around. Again, the key point here is a clean pleural cavity. That is, a pleural cavity where the fluid can run freely in all directions, not one there's a previous thoracotomy or, bad TB or, name your reason for pleurisy and for photic inflammation, but and then adhesions, I think that's a caveat also. But we're talking about the normal trauma patient that comes in with out too much of a pre-existing thoracic history, if you will.
Okay, so you have any other tricks to get complete drainage of that hemothorax?
I think it's important that you make sure that the tube does, obviously there's just simple things. Make sure the tube isn't kinked. You direct it, posteriorly. I do like the idea of putting it, I always did it at a low angle. In other words, so there's a little bit of overlap as it goes. I think that makes it easier to direct the tube, and also it's easier when you pull it out because there's a little bit of a tissue flap. You go, classically over the rib, and so you're putting your incision lower than where you're going to go in, and there's a little bit of a sub-Q and maybe a muscle flap that allows you to put pressure on it when you pull the chest tube also. So I don't think a chest tube should go straight in. I don't think that's the way to place it. I think it should be at least semi-tunneled, if you will. It's not a very long tunnel, but it allows you that flap, and I think it allows you a little bit more control going in. You can feel the rib. You can stay away from the vascular neuro bundle that runs under the rib above. And so I think that just is a good way to go. I don't roll the patients around or anything like that, trying to get them to do it. I think, I think those things work pretty well. Not all of them will drain, but I think I don't find a big difference in just that kind of very standard but, well-executed technique.
Some literature suggests that we should be irrigating that chest tube after tube placement before we hook it up to final suction, not irrigating it once suction is hooked up, but irrigating the chest with saline after it's placed. Do you subscribe to that technique?
I don't, but I don't have an emotional, well, I do have an emotional problem with it. I don't have an intellectual problem with it, actually. But I could see where possibly, getting some early clot out and stuff like that might help, and it might clear the tube. I think also the other thing is you know once you put a chest tube in, you have to kind of make sure it's working. You make sure it's the levels change with inspiration. On whatever way you're measuring that, you're looking for air leaks and stuff like that. I think they require at least periodic assessment, and I think sometimes that's lost. But no, I have not irrigated, and I really don't have a comment about it. I think it could make some sense. You always hesitate that how sterile are you putting irrigation fluid in the resuscitation room through a chest tube. But I don't know that it would make much difference. It would be interesting to see if there's data that comes out on that.
Well, you've done everything right, and you feel pretty good, but the chest x-ray that you get 24 hours later shows that you've got a retained hemothorax. So you're 24 hours into the hospital stay. Do you start thinking about every trauma surgeon's favorite operation these days, which is a VATS, or do you just wait and see?
Well, I'm a full card-carrying member of the VATS Club, so I think that works out well. That position is based on some experience with I think, somewhat under-recognized, and maybe even more so now, morbidities associated with a retained hemothorax. The chances for empyema, decortication, needs and all that kind of stuff, I don't think there's any series and say it points back to some kind of retained hemothorax as the number one cause. And we're talking about, let me be clear, we're also talking about a position where the chest tube's in. I'm not talking about maybe watching a blunt trauma hemothorax that's small. I'm talking about now where you've drained the hemothorax and the chest tube's in, and I think there's a difference there. And when we talk about, retained hemothorax is evolving into empyemas, one of the risk factors is always a chest tube. And so if you've committed to a chest tube, for whatever reason you committed to it, I think if it's in, then you're obligated to really drain that hemothorax as best you can. And if you can't, then I think it requires some intervention. We certainly have had some experience using thrombolytics if there's no contraindication for that. I don't think you lose much by doing that early on. But I also think a relatively early VATS, I don't think this should be done a week later. I think it should be done if you can't get that thing drained in 2, 3, 4 days. The clot that forms in there doesn't usually come out with the tube, and then you're looking at taking it out with the VATS. And I think that can be done, with relatively low morbidity, and you can do it almost through what it really amounts to another couple chest tube sites. And you can, with really not even fancy instrumentation, get the clot out and then place the chest tube back and go from there. And going back to what you said before, a lot of times you irrigate quite a bit when you're doing that. So you wonder if maybe that irrigation early on is a possible way of mitigating this retained hemothorax in the long run. But, breaking up that clot, and usually what I find is at 3 days out is a retained clot that isn't going to come out with the tubes.
Let me just push a little bit. One of the arguments I hear every once in a while until you get your anesthesiologist up to speed, I would say, is that, if we're going to do that, it's a left-sided hemothorax, and I'm going to have to put a double lumen tube in. Is that what you routinely do and put them in a decubitus position, or do you do them on their back in the operating room without a double lumen tube?
Actually, I've done both. A little bit depends on how what I want to see is the expertise and the willingness of the anesthesiologist. I think that was part of your question, and I think that's some anesthesiologists are very, very facile with the tubes and put them in, and I don't think there's any question that a posterior lateral positioning just kind of can help. You can certainly do it supine, and it can be done, and it can be done without double lumen tubes. Certainly, we do major things in a hurry without double lumen tubes, so you can certainly do that. But it does help to be able to regulate the ventilation in that lung. It can collapse. You can see a little better. You can manipulate your catheters and suction catheters and whatever a little better. So I think you can do it either way. But I think if you have the choice, these are not usually emergent operations or something you schedule in the light of day on post-injury day 3 or something, that you can do. And if you can do it with a double lumen tube and you have an anesthesiologist willing to work with you, I think that works pretty well. Can it be done supine with a single lumen tube? Absolutely. You're fighting the lung a little bit, and there's there's always a risk that when you're gaining access with an open lung, with a lung up, it's going to be a little bit more chancy to cause an injury, but usually not.
All right. Well, we can't finish blunt chest trauma without asking you about rib fixation, and I'll just lay it right out there. So you got any tricks for patient selection that make sense? And what do you do to get the procedure done?
I think that's an excellent question, and this is an evolving area. So let me just spend a second here. I thought rib fixation made a lot of sense in the late phases when you had somebody with a clicking rib and it was causing, pain. It was either do the rib resection or fixate that rib. That made a lot of sense. I don't think anybody would argue with that, but that's not the majority of what we're talking about now. We're talking about somebody with a flail chest or several, fractured ribs with displacement that are causing inability to ventilate or get somebody off of mechanical ventilation. They can't self-ventilate well. So I think you have to really look at the rib fractures and whether number. Is it a flail? Is there underlying pulmonary contusion? And even if it's not a flail, how displaced are they? And if you've gotten a CT scan of the thorax for whatever reason, the reconstructions on that I think the 3D reconstructions are really key because I really think it does help you see what you're up against. It's like an orthopod, or orthopedic friends looking at an X-ray of the bone that's broke, and because the chest X-ray just doesn't quite, help as much. And I think if they're severely displaced, even early on, there's some literature starting to support the work out of Denver, and there's even some meta-analysis to say this is probably the way to go early on to avoid a long-term ventilation, pain, and some people even suggest it reduces tracheostomy because of the reduced ventilation. So I'm looking for 2, 3, 4 ribs. I think it's very hard to stabilize ribs like 1 and 2, and I'm not sure you ever have to stabilize ribs 11 and 12, but sort of the ones in the middle, 3 through 9, 3 through 10, something like that. I think those are ones that if they're broken, especially in 2 spots, it helps. It's also something I think you can do if you're going to do something else. If you are doing a VATS or something else at the same time and they're going to the operating room at that post-operative day 3 with multiple, I think that's a good combination. It makes a lot of sense to me to do it at that time.
So have you progressed to absorbable plates and screws?
No, but it's again, I don't think it's philosophical, and it certainly makes sense. Like anything else, if the thing heals, if you get it together for, I guess 4 to 6 weeks. I don't know that a rib would be much different than any other bone. That would make sense, and I certainly don't have a. I think that in somebody's hands it can do that and be familiar with it. I think whatever rib fixation you're doing or somebody in your group's doing, you need somebody who's familiar with it and does it on an often enough basis. They feel comfortable with it when they do it. There's certain courses to do it and all that kind of stuff, but doing it for the first couple times I don't think is anywhere near like doing it on a pig model or something. There's various methods and commercially available fixation devices. I'm not sure I have any real huge thoughts of one over the other. They all have some advantages and disadvantages, but I think you should be comfortable with the one you use and you should be able to use it. But I don't know that I really answer your question more than it badly displaced ribs, flail chest on somebody who's just not responding, well to the pain. And if they're really displaced, I think it's just hard. They don't heal as well. They just don't do as well. And I was slow to come around to this particular thing, but I think sometimes you can identify pretty early on. And again, there's literature dripping in the paper that came out of Denver, and also some meta-analysis that they're probably with the right patient selection, but there's the bugaboo, and I think we keep looking at that. We do look at PO2 FiO2 ratios, but I think that's more indicative of probably the underlying contusion than it is actually the rib fractures.
We've been saying the same thing for the last 3 issues of CSAP, that it is still, the patient selection at least, is still in evolution.
I would agree with that, but I think we've also shortened the time frame, as I alluded to before. I think that we've decided that there are certainly more patients than we thought initially would benefit from early fixation than we thought 3 CSAPs ago.
Okay, that's fair. Well, let's take another scenario that is not very common but does occur and is vexing in a lot of different ways. So You have a young patient admitted after blunt trauma with long bone fractures. His spleen is treated non-operatively. His femur is rotted within 24 hours. And as he awakens from anesthesia, he is mentally confused, which was not the case when he was put under anesthesia. So someone mentions fat embolism. Is that reasonable?
Yeah, it's reasonable, though, if you look at the pathophysiology of fat embolism, one of the best ways to prevent it is to do, fixation of long bone fractures. But then again, that was always listed as a risk factor, so it's always hard to know where that goes. It's certainly reasonable to look at it. I mean, it wouldn't be the first thing that jumps to my mind for just mental confusion.
So how do we make that diagnosis then?
Well, it's clinical. You ask good questions, John. It's clinical. So, there's usually a component of respiratory distress. So the mental status changes, I think, that were classically thought about was mental status changes, hypoxia, and a rash were the kind of the classic signs of fat embolism syndrome. But you can see, certainly along with the respiratory failure, people are usually tachypnic, and certainly their heart rates are a lot of times elevated. I've either been fortunate or unfortunate, whatever. When I've seen this, the vast majority of the patients I've seen have had this anterior sort of trunk, axilla, petechial rash. I've seen it. And so, and also an associated drop in platelets. That's been pretty consistent in the patients I've seen. And so I think that goes along with it. So it wouldn't be the first thing I would think about when they came out of the operating room. You'd be looking for all the other reasons, hypoxia for other reasons or whatever, hypercapnia, drugs, all the things that would cause somebody to have, mental status changes along it. But if the patient has this collaboration of hypoxia, which can really be going to ARDS pretty quickly, and this drop in platelets and this petechial rash, at least in my mind, that's what I've seen mostly on these people. That you come up and you say, "Hey, I think this is fat embolism syndrome." Obviously, in the right clinical scenario, they associate it much more with long bone fractures. But if you look at the list, they've been seeing a lot of different, different pathophysiologies. But certainly, major trauma with long bone or pelvic fractures are way up the list.
What's the treatment? Is there a drug we can give these people, or what do we do?
Yeah, so you treat them supportively. Again, great question. You treat them supportively. There has been some whiff on and on of using steroids, and that has been controversial and somewhat equivocal in its nature. It depends on the pathophysiology here, and there's two, I think, overlapping thoughts about where this fat embolism comes from. One is actually fat is actually embolizing from some place. Like when you're doing the IM rod or something, that the fat actually ends up in the circulation pushed in. And there's again, going back to Dr. Robert Wilson, he believed very much in that pathophysiology. And there's actually a really good paper from a few years back now that actually witnessed they were using transesophageal echo during a rotting of a femur, and when they pounded the thing, these globules went by in the transesophageal echo, and the patient then developed all the signs and symptoms of fat emboli syndrome. The second one is that it's free fatty acids caused by an inflammatory cascade, and I think that's also that causes inflammatory changes in the lung. And sometimes everything that looks just like fat emboli is seen in somebody like in a burn patient. Well, obviously, in a straight burn patient, there's no bony marrow to be out there. So I think there's a combination. They're not mutually exclusive, from where they goes, but there's been evidence for both sides. The treatment's supportive, maybe steroids. We don't use them here, but it's been certainly said to maybe make a difference. The best way is to, resuscitate the patient correctly, fully, adequately, and then to stabilize any long bone fractures. And I think in that, so the scenario you gave, you already did the thing where you're hoping it would prevent it, and you did it early. I think it was seen more often maybe in the days of traction when the fixation wasn't as good on these long bone fractures. But these people get pretty sick, and their platelet counts can drop. I have seen mostly, though, the ones that I've seen have had the petechial rash, so that's kind of bailed me out in the diagnosis.
Well, let's take another common dilemma sometimes, and that is you have a patient who is admitted after a motor vehicle crash, and they have a wide mediastinum. What's the workup in Detroit?
That's an easy one. That's a CTA. It's a CT with, properly timed contrast to get a good look at the arch in the major vessels. I think that's the right answer in 2019.
Okay, I threw you the easy one first. So now you've got a major deceleration injury based upon the history, what the car looks like. You got chest bruising, but gee whiz, the wide mediastinum is not there that you were expecting. What do you do?
Okay, so the thought would be, I'm basing the wide mediastinum probably, or not wide mediastinum, on an AP chest x-ray that may or may not be in a supine position. So, we're talking about the accuracy of that, but that usually overcalls a wide mediastinum rather than the mediastinum. But let's say we'll use your criteria. The patient's got an AP film with a normal mediastinum.
I don't really care if it's a PA or an AP. I just want to know you've got the history, you've got the paramedics screaming at you. There's no wide mediastinum. What do you do?
You probably, with the chest viewing, and if it's a 70-mile head-on crash, they probably get a CT of the thorax here. That's just a true statement. Though the incidence of picking things up is pretty low, the problem is you wonder if you miss something. But again, to miss a significant injury is, it has a lot of, sequelae to it. Also, in that clinical scenario, a lot of times you may be evaluating the lungs or, multiple rib fractures or sternal fracture, so you may be getting the CT anyhow. So if you're talking about, in that scenario, I think you're getting the CT for maybe other reasons and you're piling on with the aortic arch. I think most places, the patient you described probably gets that study. Whether it's being overused or not, I guess is a good argument. But if you're asking me, that guy in a high-speed classic, my aorta could be ripped, and he's got bruising of the chest, I would work that patient up with the CTA, knowing it's a low-yield test.
Okay. All right. So I think we can move on now. So let's talk about the patient who has an injury. And are we using a grading system now that helps us make decisions about treatment?
We are. I don't use it much here. There's certainly grading systems that are used. The biggest one is, I think the biggest difference is that intimal flap, non-intimal flap, small, less than 1 centimeter type defects. And I think most places, most of those people would be observed. I don't want to speak, too much. And also in this particular place, since I don't do TVARs, which is the way they're repaired here mostly when they're doing it, and I don't do those. The open things in the past, certainly I've been a part of, but the TVAR, which is the way to go now, the thoracic and vascular surgeons are making that decision more. And I want to say I've abdicated that, but I'm allowing their expertise for the use of these placements. But they certainly small intimal flaps, or is it a ligamentous, diverticulum, sort of like that. Those things come up once in a while, and some of them have been observed. And I think it's common sense scoring, and then that, how big this thing is. But we haven't really subscribed to that here. I've read with some interest about it, but the operation we'll do here for them is an endovascular repair, almost invariably.
And if they have one of those small intimal flaps, do you treat them medically then?
Yes. I mean, it's in here again. It's in consultation. I think if I'm not going to be the guy doing the TVAR, I make sure the guy that might be doing it is involved in the decision making for the guy or the girls in that decision making process. I think that's important, and I think most general trauma surgeons wouldn't be the ones doing the TVAR. So I think for the vast majority of people, we're talking about taking care of trauma in either community or rural or even inner city settings. Most of the time, the initial evaluator wouldn't be the person doing that. So I think diagnosing is important. If you certainly think there's trouble doing the controlled blood pressure, and also I haven't ever run into a lot of significant aortic injuries that you weren't suspecting based on the chest X-ray, not confirmed on the CTA. So I haven't been surprised by significant ones. I've certainly, in the scenario we just talked about where you got the CTA, you saw the intimal flap and you let them decide what to do with it. Occasionally we found some more there than we thought with a false lumen. But again, some of those CTs were done for reasons other than just evaluating the aortic arch.
Well, let's move on to penetrating chest trauma. And what do you think about the East and West guidelines for ED thoracotomy? Are they reasonable, or do you think they're too aggressive? I happen to know that you probably have a fair amount of penetrating chest trauma up where you work.
Yeah, so we have that. So just to set the basis, especially the East guidelines basically say if there's signs of life, you should absolutely do a thoracotomy, and even if there's no signs of life and it was penetrating, maybe you should consider it. The only one you shouldn't consider is no signs of life and blunt. If I'm going to just kind of, decoct it down to its most simple form, and that's very aggressive by most people's standards, that you would only not do a thoracotomy and blunt trauma, and that includes extrathoracic injuries. They said you could consider doing a thoracotomy, resuscitative thoracotomy for extrathoracic injuries. That is, they bled out from a different place, a femoral artery or something, and can do that. So having said that they're very aggressive, I happen to like those criteria and often quote them to the dismay of people around me to say that we have had, albeit rare, survivors from a femoral artery where the patient was asystolic with maybe a sign of life, maybe a respiratory effort, and we cross-clamped the aorta in the chest, and that person left the hospital neurologically intact. And you never want to talk about anecdotes, but it's hard sometimes to do that to a young person when the algorithm is open the chest or declare them. And so I think with blunt trauma, that's pretty clear that your chance of getting somebody neurologically intact out of the hospital is so abysmal to not put the personnel through the risk of a procedure, and then you start looking at also, resource allocations in a hopeless situation. So I do think they're aggressive, but I happen to, to like them, and I like that East guideline. I hope stands for a while, otherwise I don't know who I'll quote.
So when you do a resuscitative thoracotomy, you got any tricks for making it a slick procedure?
Arm goes out to the side. This is a left anterior resuscitative thoracotomy, obviously, and so arm goes up to the side. I think the incision goes below the nipple, and it has to go in a hard arc towards the armpit. I think that's the thing that's maybe for somebody that doesn't do these often is one of the germane points. You really have to make that curve go up high into the axilla, otherwise you don't get the right exposure for the ribs. Usually a knife through the skin. I actually like if I can pop a pair of Mayos into the intercostal space and then use those in an open fashion and push, especially if I'm helping a resident with it. I like that they do that. It avoids laceration to the lung and stuff like that on the way in. We've seen a few of those. And then, it's not a time for limited exposure. The other thing is, if you're going to do this in a place where in the ED, if there's some way you can get some light in there, it helps a lot. And I'm not... It sounds funny, but I think that's an important thing in a resuscitation bay to have adequate light. We have an OR light over our one, and that really helps a lot. And then either rib spreader will work, and then you go from there. You examine the pericardium, looking for tamponade. I think it almost always gets open. Obviously, you're going to evacuate blood. I sweep the lung up to get control and cross clamp the aorta. I like a Satinsky clamp. I find it easier to use against it. If somebody's already got an NG tube down, that also helps. So you don't clamp the esophagus, which is easier to do than you would think, especially if the aorta is flaccid. So I think the biggest thing is that initial incision has to be hard towards the armpit and a hard curl, or the exposure isn't what you want it to be. And it's limited as it is, but it does give you a reasonable exposure to the heart to do the things you need to do and open the pericardium and open cardiac massage and in fact, even cardiac repair.
When you're using the Satinsky, do you have to first bluntly expose the aorta at the diaphragm?
I do, though you can get a pretty good Satinsky grip if you just take the thing open with the flat end and push it hard against the spine, against the aorta, and clamp it. You don't get 100%, but you can get a pretty good clamp just doing that. I think if you can get just a little bit of pleura open up there, it helps a lot. I don't hook it all the way behind necessarily in the first try. I just find that as good as doing, I just like the way it pushes against the spine rather than, you certainly can use an open, straight clamp, and that's what a lot of people use. I find that edge of the Satinsky easy to use and clamp, but again, that was a preference, developed over time.
Well, let's ask a favorite question. So you got a patient with a gunshot wound to the abdomen. The heart is still beating when the patient arrives. You do an ED thoracotomy. or you're thinking, gee whiz, what should I do? Do you clamp the aorta in the chest or the belly?
If I decided that the patient was so hypotensive and arresting that I needed to do an ED thoracotomy, they're going to get clamped in the chest. I also find it easier. That's just an easier, in some respects, that's a quiet place to clamp. In other words, you can get it on there, you have good control. And also, once in a while, you're surprised by the gunshot wound of the abdomen actually ended up in the chest also. So there's that scenario. Dr. Wilson with Dr. Winsick wrote a paper about where you clamp on the aorta. Certainly controlling the abdomen is another thing, but you're not going to do a laparotomy in the resuscitation room, and it depends on your local facility's, time to the OR where it goes. But even in a place like here where the time of the transport from the ED to the OR is relatively short, same floor, just down the hall, that kind of thing. I favor if you can clamp in the chest. The downside is you've opened another body cavity. There's no question that there's some morbidity to doing that, and if you're treating a left iliac vein injury, well, I don't know. Did you really have to do the thoracotomy? It depends on the physiological state of the patient at the time. But if you can't get the patient to survive to the OR, or you're going to be really an extremist by the time you get there, and you've added that time on, I think it's the quickest way to clamp an aorta is through the left chest.
Well, let's talk about a parasternal stab wound, and you think they have a penetrating cardiac injury, but they have some vital signs. Do you use ultrasound or a pericardial window to prove or disprove that they have a penetrating cardiac injury? I
don't know that there's any real use for a pericardial window in the acute setting anymore. The ultrasound, every generation gets better. Even an old guy like me can get it on there and look and see pretty good cardiac motion in pericardial fluid. So I think and that's just going to keep getting better. The probes keep getting better, and even in these rotund patients, I think you usually get a line. So I think you can put a probe on the heart. It's to the point now where the ultrasound is the stethoscope of this generation, and so I think I don't think there's any question the ultrasound's the way to go. With that, when you're trying to figure out if you've got blood around the heart in the acute setting in the trauma bay.
What about when you have a left hemothorax as well? Does that decrease your accuracy?
It does, absolutely. So then the scenario would be, well, can you put a chest tube in, drain it, see if you can see? Even then, it's a little bit harder. And also, you're obviously working on the patient's vital signs, right? And so, and what I obviously see in tamponade or what you see in tamponade is, tachycardia is usually pretty high up the list. If they're bradycardic and hypotensive, then you're usually about ready to open the chest anyhow, because that's a pre-arrest situation. But I think the combination of that, and also I do think narrow pulse pressures do raise their head in this situation, and it's one way to. Sometimes it's good to pay attention to that diastolic pressure, not just get fixated in the systolic pressure. If there's narrow pulse pressure with tachycardia, it should be on your list. But the ultrasounds are getting better and better, and you're right, fluid in the left chest compromises a bit. It's as good as a CT scan was in 1990.
Okay, all right. Well, what about a stab wound of the right ventricle? How do you fix it?
So I use Prolene, and I like pledgets. I like Teflon pledgets.
Okay, and the left ventricle, any different?
I use the same thing, but I think paradoxically you need pledgets less with the left ventricle because it holds the suture better. The right ventricle is especially again in a training situation, it'll tear if you're not careful, and so it depends on the size of the hole. But I'll use pledgets if you don't necessarily have to do them. There's arguments about that all the time, but I like a horizontal mattress, double armed 3-0 Prolene with the Teflon pledget. I find that the best way to control a ventricular injury, or for that matter, an atrial one.
Well, let's move on to a little different. Let's move down a little bit on the body, and a lot of literature out about penetrating wounds to the right upper quadrant. And let me ask you, are you managing a gunshot wound to the right upper quadrant who's hemodynamically normal and has only right upper quadrant pain? Is that somebody who goes to the operating room immediately or is evaluated with a non-operative potential plan?
I think that a valuable patient, in other words, somebody I think the patient has to be awake and give you a reliable physical exam along with everything else. I think some of those can be managed non-operatively. If it's imaged correctly with a CT scan and it shows a clear bullet track, and in the hole, if there's a hole in the diaphragm, let's say because it's that high up or whatever, that it's right with the liver, the chance for a diaphragmatic, long-term diaphragmatic problem is low. You can almost hear my voice. I'm fighting all that, okay? So it is. I think that can be done. I tend to operate on these and take a look, and fix whatever liver holes need to be fixed. Fix the diaphragms wherever they need to be fixed. I find holes in the diaphragm almost invariably need a chest tube above it, so do that. And I'm again, as the imaging is better, but there's a lot of bad things in right upper quadrant, John. There's the portal vein, there's the pancreas, there's the vena cava, there's duodenal injuries. I find it hard not to look. You could argue the difference between putting a laparoscope in or doing a full laparotomy. I think that's a argument you could have, but I have a hard time not laying eyes on the injury. Though there are many studies that have shown, and many anecdotes, that in the right place with good imaging, and not anything that would preclude you to stay out of the operating room, that you can manage these non-operatively. They all have the same sequelae of, even if you operate it, a deep gunshot wound can end up with you can end up with hemophilia down the road whether you operate it or not. It doesn't affect that, but yeah, I think you can do that. I just don't have a lot of experience with it.
Let's talk about colon wounds. Let me just ask a simple question. So penetrating wounds to the colon, gunshot wound, stab wound, is colostomy dead?
No, but it's moribund. I do think that, we went through all the things that we needed to do with colostomies, to say about the classic, Stone article about the criteria for doing a colostomy in colon trauma. It turns out that in civilian trauma, for sure, I don't want to speak too much for high-velocity military, and occasionally you'll find a rifle bullet injury where higher velocity is above 2,000 feet per second in the muzzle velocity, that you start wondering if all those would apply. But to your point, is that I think the vast majority of colon injuries can be repaired primarily in almost any setting. There's almost invariably no stab wound and no that can do it, and most gunshot wounds. The places that I think it's hard to primarily repair is obviously if there's massive loss, or I think what I've seen more than massive loss in my career is a mesenteric injury compromising the blood flow. And so if that happens, then I think it's hard to do anything except resect that area. Now, if you resected it, what do you do with it? And I think, the literature more and more points that you can probably put these things back together. I think you do use some judgment about how fast you can do that if there's multiple injuries versus speed, but there are more and more that that you can put them back together. Maybe the only area, and this was a paper out of Atlanta some years ago, that maybe a gunshot wound to the splenic flexure in a hurry, maybe you shouldn't put an anastomotic line there. And that series that came out of Grady, the ones that leaked were always in that area, and some of them were pretty devastating complications. So maybe with that one caveat for that watershed area, that would be the one I'd be the most circumspect on. Do we still do colostomies in Detroit? Yeah, we do a lot less of them than we did in the 1990s or 2000s. I think you can get away with not get away with, but I think it's proper treatment to primarily repair the colon most of the time.
Okay, well, let's move a little bit distal, and let's say you got a rectal injury from a transpelvic gunshot wound, and everything else looks okay, the vascular supply, but you definitely have a rectal injury. Has management changed for those?
Well, certainly it has changed. I mean, the original, diverting colostomy, pre-sacral drains, and sacral washout, I don't know that anybody does that. I don't know if anybody gets out a 3-liter bag, puts betadine in it, and washes out the rectal stump anymore. I don't know that that's been done, and it's almost embarrassing that I know how to do that I've done that in the past, that you could do that. And again, for civilian injuries, I do think rectal injuries are a little different. I think the mantra for a rectal injury is you repair what you can see, and if you can't see it, but you've diagnosed it by scope, blood in the rectum, whatever. I think if you can't see it and can't repair it, obviously, you're not going to dig the rectum out. You're obviously going to divert. If you can repair it, I think it's much more controversial. So you gave me, I think, in your wisdom, maybe the one that's most equivocal, right at the rectosigmoid junction, anteriorly, and you can repair it. I think, again, it's a judgment call, but it's an option to repair that, and that has evolved through the way. I don't know if you get faulted for doing a colostomy in that situation, but I think most of the time you'll be able to treat that successfully that way. Again, making sure you get rid of all the devitalized tissue and all that. And it's somewhere in my mind, the stool burden of the area and spill still comes into my mind. I don't like when there's a large amount of stool spill, which sometimes is out of rectum. I might repair it and do a colostomy upstream. I still have that in my head, anyhow, that I find gross contamination, a bowel movement in the abdomen type contamination, hard to trust a suture line in the middle of.
And retrorectal drains are out.
That's what the literature says, is that you really don't need them. If I put one in the last 3 years, absolutely. With I think a bad posterior wound that I saw on a flux segment on somebody with a gunshot wound, I've definitely put them in. I'm never really sure what comes out of them. You put those drains up there. Am I really decompressing or stuff like that? I may be hanging on to something a little too long with that, but most of the time it does not happen. Though I have seen in the last couple of years complication transferred in where the patient was putting stool out of gunshot wound out of his buttocks in something that wasn't diverted. So, I mean, those things still, and that patient needed some work to be done and needed to be diverted and washed out. So it can still happen. You can still get those kind of fistulas from it if they're not diverted, but again, I think that was probably inappropriate management of the diversion more than the drains. The drains don't add anything usually that a colostomy does.
Well, let's move even further, and let's talk about extremity wounds and potential vascular injuries. There was a question actually in CSAP 16 that generated a lot of activity, if you will, by readers of CSAP asking if it was really still appropriate, and that was whether proximity is still used as a reason to perform further imaging studies to exclude vascular injury. Do you still use proximity as a guide?
Not very much. I wouldn't say it's totally excluded. I mean, it's used obviously in the negative way. If there's a gunshot wound to the thigh that never goes medial to the femur, you're not too worried about a vascular injury. So, I mean, obviously there's a negative side of it, just common sense. I don't think the classic things about proximity, or even we used to talk about nerve deficits as the nerve ran alongside the artery. I don't know that those have really held up through the years. Is it perfectly obviously you're going to look where it is, and we've all of a sudden the trauma band looked and thought, wow, if I was trying to shoot somebody in the SFA, the superficial femoral artery, I'd shoot them there. And so it does go through your mind. I'm more likely to use that for something like getting an ABI or a Doppler type study than I am to go full imaging. Having said that, again, the use of CTAs, particularly in people transferred in, it seems like it's almost ubiquitous. Somebody has a lower extremity gunshot wound and they get a CTA, and a CTA now is, the people are in-house, the technology's there, and the views and the recons are, as good as a 1990 agram. I mean, they're not therapeutic, but I mean, for diagnostic stuff, we're due. So the short answer to your question is not really. I use it more as an exclusion than I do it for further studies. But I don't usually get a CTA or further imaging studies based on just proximity. You're looking for the hard signs.
Do you get ABIs routinely, or if you've got any suspicion, you just go right to CTA?
If I have a suspicion, if I have really hard signs, obviously going to the OR. I mean, pulsatile bleeding, right? Pulsatile hematoma. But if I have soft signs, they said it bled a lot at the scene, and there's a bit of a hematoma there. Maybe the pulse is off just a little bit or something like that. That person with the soft signs would get a CTA. If it was proximity and stone cold normal, I might get ABIs, but I don't. I don't usually. You have to compare it to the other side, obviously, with an ABI. But I think a CTA, again, all things being, equal, I'm always conscious of how much dye we're giving these patients now. The 65-year-old diabetic is different usually than the 23-year-old gunshot wound victim. But I'm always conscious of the dye. But most of those people would get a CTA, not based on proximity, but based on something else. I do think hard signs you can evaluate in the operating room, and also the use of a hybrid OR is, wonderful in this setting of evaluating and treating, extremity vascular trauma.
Well, sitting here, I am a little discouraged that our time is about up this morning. It really has been a pleasure spending time with you, Jim, to discuss some of these CSAP 17 topics from the trauma category. Any closing comments for our audience about the CSAP process or CSAP Audio Companion?
I would reiterate, I think I saw in the past, it's been a real learning experience and a pleasure for me to be associated with CSAP and the audio components of it. It makes you really look at what you're doing. And I always said I learned more than I ever contributed to the CSAP process. I learned more from being there, and I think it's a credit to the process and actually to you, Dr. Weigelt, you're putting people in a room that are really concerned about getting these questions right, bringing expertise from various fields, and as you well know, robust and not always concordant discussions go on regarding these questions. I think it's a wonderful opportunity to give opinion by people that are out there looking at the literature, but more importantly, clinically doing the things that they're talking about.
I thank you for those comments, and I thank you for your participation in those discussions because I, too, enjoy them. And again, I learn about as much as any of us at the table. So once again, thank you for spending your time with me today, and you have a great day.
Thanks for having me, and you too.
That's the end of this session for this category of the CSAP 17 Audio Companion. This category will continue in the next session.